To end the day, we have an exciting panel planned, Planning for Knowledge Translation and Policy Impact. Our first panel presentation will be given by Mr. Gordon Duff. Mr. Duff has more than 25 years of experience in human services and advocacy in a career spanning New Zealand, Canada, United Kingdom, and Australia, and across the academic, government, non-government, and business sectors. Mr. Duff has supported the development of the National Disability Insurance Scheme, NDIS, in Australia as a member of the Federal Ministerial Expert Advisory Group on Sector and Workforce Capacity and has led the establishment of the Center for Applied Disability Research. Mr. Duff is a recipient of a Fulbright Professional Scholarship in Nonprofit Leadership and spent time in 2019 with U.S. agencies that facilitate innovation across the U.S. disability service system. This supported the development of innovation policy in the context of Australian disability reform, including the establishment of a disability research and innovation partnership in Australia. His presentation today is Research Informing Policy and Practice, Recent Examples from Australia at the Micro, Meso, and Macro levels. Following Mr. Duff's presentation, we will hear from Dr. Kathleen Mullen. Dr. Mullen is a senior economist at the RAND Corporation and director of the RAND Center for Disability Research. Her work addresses the economics of disability, health, and retirement, with an emphasis on the incentive effects of social insurance programs such as the Social Security and Social Security Disability Insurance, SSDI. Dr. Mullen has pursued research on, among other things, the effects of SSDI receipt on labor supply, the effects of long waiting times and the subsequent labor force participation and earnings of rejected SSDI applicants, how changes in eligibility requirements affect SSDI or Social Security claiming, and the effects of changes in Social Security or disability insurance incentives in other countries on labor supply for workers at older ages, and what those findings suggest about potential evaluations of reforms in the United States. Her presentation today is Disability Policy in the United States, Evidence and Implications. If you have questions during the presentation, I remind you, please ask them in the chat box, and we will address them as we can. Using questions from the chat box, I'll moderate a Q&A following the conclusion of both of their presentations. And with that, Mr. Duff, are you ready to begin?
Yes, I am. Good morning, Donna, or good afternoon, rather. Thanks very much. Hello, everyone. So today what I wanted to do was just talk to three recent examples from the Australian context where there's been an attempt to synthesize evidence for the purposes of supporting better policy and practice. So really what I want to do, they're all three recent examples and they all occur in the same context. One's at what I call the macro level, which is, as Donna mentioned, has been our recent attempts and ongoing attempts to completely redesign the service system to move to a national system from 8 different jurisdictional systems. And then the other two examples are at the subsector level. One in particular supporting organizations that provide early childhood intervention, and another which is for organizations that provide community participation. And the main point I want to draw out really is, though they were all fairly solid attempts in their own right to synthesize the best available evidence available in some cases globally in order to advance better policy and practice, they've all sort of come off the rails a little bit. And I think that the reason for that, really, the main point I want to draw out is really the importance of having a knowledge translation infrastructure or scaffolding to help get that knowledge out to practitioners or policymakers or organizations working in the field. So I just want to provide a little bit of Australian context, not too much, just to kind of set the scene. So, and the way I want to do that really is just talk about, for our first example, which is our journey of change to kind of reform the national service system, is just offer some insights into where we were a few years ago when the conversation started about reforming that national system. And I think the best way to do that, obviously, is to look at the outcomes that were being achieved for the intended beneficiaries of that system as people with disability, their families and carers. And you can see on the slide there probably that unfortunately our story in Australia has been about what's not working well compared to other countries that share a kind of socio-political history. So in terms of comparing to OECD countries like the US or Canada or New Zealand or the UK, it's a simple fact that compared to other Australians, people with disability are more likely to live in poverty, have poorer health, have fewer educational qualifications, be out of work, be more likely to be subject to violence and abuse, live in insecure and unsuitable housing, and experience inequality in access to public transport and other services. And I think that what happened in Australia nearly a decade ago was that this really contradicted the nation's sense of self as offering a fair go for all citizens. And so our story of change, as many stories of change, started with political leadership, and a national conversation about the Australian Disability Service System was started in earnest probably back in about 2007, 2008. So, you know, we are talking about something that kind of happened, it started about a decade ago. And this is what some people said about their services back then, that they can't get the support that they need, that there's not enough money available, that there's not enough information and not enough choice. And so the formal assessment of it was really that the disability service system was underfunded, unfair, fragmented, inefficient, gives people with a disability little choice and no certainty of access to appropriate supports, and that it was essentially unsustainable on multiple grounds. What one person beautifully described, if we could go to the next slide, Donna, as a confusopoly, which I think is a beautiful word. And if we could go to the next slide, I think the other important context is where we were in terms of the evidence base for Australian disability research. And this is also not a pretty picture. The characteristics of our local evidence base here were essentially that it was fragmented, that there was no critical mass of research topics on areas that were important to the reform agenda, that what was being done was very hard to access because typically it was locked up behind paywalls and academic journals. There were no kind of clearinghouses or those sorts of things to help people access the best available evidence in an open source way. And that what was being done was really not well aligned to the reform agenda. And that lots of studies essentially describe the problem. So these are the findings of an audit of Australian disability research that were done in 2014 and 2017. So we had, you know, the voice of consumers saying one thing, and then on the evidence side, we had a pretty low base from which to start. So in terms of the first example, really this is a story. I don't want to cover too much of the kind of scheme because I've got references that people can follow up later. But this was really a story about looking around globally in building an entirely new service system, looking at what other service systems were doing, what other jurisdictions were doing, and trying to rebuild something from the ground up based on the best available evidence about how do you actually deliver a disability service system which is efficient, effective, person-centered, takes a life course view, is nationally equitable for all citizens. In Australia, these for us are kind of typical or commonly considered sort of high order social policy goals. And so that was the task really that myself and a number of other people who have been involved in designing the new scheme were tasked with. So virtually all of the main design features of our National Disability Insurance Scheme have actually existed in other countries or within Australia at the state-based systems. In some cases, you know, for many years, in some cases with things like self-direction and direct payments for over 30 years. But really the job was to kind of look at the evidence and build something from the ground up. So firstly, at the level of principles, the NDIS is about implementing Australia's National Disability Strategy, which is in turn the way that Australia meets its obligations under the UN Convention on the Rights of People with Disability, which if you know that, you know itself is grounded in the voices and lived experience of people with disability, their family and carers. So it's about the best evidence that you can get. And some of the other principles about person-centered design and people with disability being in control and having choice over their service provider, they kind of naturally follow from features like portable individualized budgets. Another key feature from a human rights perspective is the legal lifelong entitlement to what's called reasonable and necessary supports. This is possibly unique to Australia, and I'll talk a little bit about that later, but that was a feature that was kind of, that we didn't kind of see in any other jurisdiction, but has been incorporated into the design of the scheme. And one of the other more distinguishing features of the system here is taking now a social insurance approach to funding disability services and supports. And essentially this means that there's an incentive to provide evidence-based services and supports as soon as practically possible in order to change that trajectory of lifetime costs and outcomes associated with the disability, as compared to the previous system, which was really about sort of spending more and more money on fewer and fewer people. And once in the system, ensuring people that have reliable access to kind of hand-holding supports to manage crises, to deal with inevitable variations, to deal with service providers, to get advice on services, is dealt with by a system of local area coordination. And that's been a feature in one of our jurisdictions for about 25 years. And that's probably an area where there's the best evidence that having that hand-holding support correlates most strongly to eventually to kind of out people's outcomes. And people might be interested to know that another feature, it's not really a feature, but important context, I think, certainly within other OECD countries, is that we are doubling the spending on disability services in Australia in order to sort of drive economic growth. We are doubling the workforce for disability services. And we think that will add nearly 1% to Australia's GDP. So taken together, we think that the arrangements here reflect the best available evidence that we could find for the most part, and I'll talk about implementation later in terms of where that's going. So what we're trying to do is sort of design a service system based on these principles around flexibility, portability, choice and control, personalization, offer people continuity, investment in capability. And I think what this is saying to Australians, going back to that notion of having a service system that better reflects the nation's sense of self or its fair go, is that you have a right to services that meet your needs. You can use it with any willing provider. You can manage as little or as much of the administration as you like with a range of budget control options. Essentially, you matter to society and the economy. You're worth the investment, and you can plan to lead a normal life as any other citizen. But I mean, while most of the features that I've sort of described have a pretty good evidence base, have been tried in other jurisdictions and have proven to be effective in terms of those higher order social policy goals I mentioned before. Not all of them do. I mean, even something as simple as the notion of individualized funding, I think in some areas is a little bit more kind of ideological or a matter of faith than based on very good long-term evidence, for that. We're by no means the first to apply that notion of individualized budgets, but I read a great review which is from Helen Dickinson in 2017. I've got the reference at the end of the presentation, which kind of concluded that that the literature is not really clear on whether these issues with the implementation of the marketization and personalization of services is strongly attributed to people's outcomes, and the extent to which the outcomes achieved, are attributable to those features or something else. So that's, for those interested more in that area, that's definitely worth a read. But despite that, we are kind of proceeding with that as a kind of key design feature. I think it also depends on what you actually consider to be evidence, because that review that I just mentioned is obviously just talking about the peer-reviewed, sort of first-tier academic journals. But certainly if you have a broader view about what evidence is, and you look at some of the grey literature in the policy pilots, for example, in the UK, by organisations like In Control, or even further, if you just sort of look at the stories of people that are using direct payments and individualised budgets to arrange their own services, then those kind of stories go a lot further back, and there is, a really solid evidence base. But I think there's a debate to be had about what people consider to be evidence. So ours is certainly a kind of a work in progress, and we're still in kind of evolution and incorporating new evidence as we go, and learning from trying to bring together design features from around the world to design what we consider to be, and we hope will be, a kind of a world-class disability service system. Ultimately, what we want to do is get this line of sight between the resources to the people benefiting from those resources, looking at the services and supports that they put in place, and then the outcomes that are achieved. And obviously that will take some time, and we're kind of really just on the cusp of going to a fully national scheme next year. So in 2020, the last of the 8 state jurisdictions comes into the national system. So we're very much kind of in the middle of this journey. I mentioned earlier that's this definition of reasonable and necessary support. So just before I get into the next 2 examples, I think it's worth just mentioning this. So this is literally the definition in the legislation, which, as you can see, the whole notion of value for money or effective services or evidence-based practice or contemporary best practice is really written into the DNA of the scheme and into the legislation. And I think that that's really important. It sort of, for me, it sort of highlights then the importance of having in place a kind of infrastructure or architecture for knowledge mobilization. Because what this means now is really you've got to have a way of getting out and translating the evidence to people who are now making, we hope, informed choices about the services and supports that they want in their life. But we don't have that infrastructure in Australia at the moment. When we look at, for example, the scale of what goes on in the US, that just kind of looks like world-class practice to us. So, saying it doesn't necessarily make it so, but at least in theory, the whole idea of funding evidence-based services and supports is written into is very much in the DNA of the scheme. I'll turn now to the second example, which is in the early childhood intervention space. So obviously this exists in the same context. So there was the same pressure for change, if you like, around the system. There was a lot of national inconsistency, lots of different models, lots of different policy frameworks and program guidelines that had been developed at different jurisdictional levels. And anticipating the national consistency of the NDIS, there was a process essentially to engage the early childhood intervention sector in a national conversation about their practice, to enable practitioners to critically self-reflect on their practice in light of international best practice, and then challenge organisations to think about how they would improve practice leadership around the area of early childhood intervention. So in our context, what we mean by that, I guess, is sort of allied health professionals such as speech pathologists, occupational therapists, family support workers, all of those people who were working to a range of different models reflecting sort of state-based arrangements. The deliverables themselves were just, an e-learning course with modules that takes about 6 weeks to complete, which you then get a certificate of completion. It's about kind of 6 hours of professional learning. And the way that was done was, in a sense, there were kind of push and pull factors. So the pull factor was from a new government agency, the National Disability Insurance Agency, which is, in our context, is kind of like a single national payer who kind of wanted this done and funded. And then the push factor was from, the peak industry association for that subsector, Early Childhood Intervention Australia, whose job it was to kind of engage people and get that knowledge out and sort of facilitate the knowledge translation. But I'll talk later about why, how, even though this work was, as I said before, that all of this work was kind of done in quite a solid way, but then the problem was that organisation was actually recently defunded. So what was meant to be a good practice story, it shows if you don't have that knowledge infrastructure or architecture in place as a kind of permanent feature of the system, then these best intentions to pull together the evidence about what works and engage practitioners in that and engage people with disability in that story, then those best attempts can be frustrated in a very short space of time with the defunding of organisations that facilitate that knowledge translation. The third example I want to mention is in the area of community participation. So again, happening in the same context, the same pressure for change, a range of different kind of policy frameworks around community participation, a range of very kind of structured programmatic approaches. We did an international literature review to really try and understand what it is, what it isn't, what it could be, what it should be. We found that there was really a very poor conceptualization of what community participation is. A range of different kind of lexicons used about community participation, not really a lot of good published literature that clearly articulates a theory of change, particularly in terms of, what's it for in relation to other service types like employment, or accommodation, or just achieving social and community participation in its own right. I'll include all of the references for this work and for the previous examples I've got at the end. So there is a literature review, there are organisational case studies, which we found particularly effective in terms of, bringing that evidence together and putting it in a form for the end user of this research, which in this case, the target audience is really people who lead the transformation of community participation within organizations. And we found the organizational case studies extremely valuable because unlike a lot of material information products, evidence synthesis information products that we can sort of borrow from other jurisdictions, we thought it would be really important to develop those in the Australian context, particularly in light of things like the reimbursement rates that apply under the NDIS, so that you can build costed service models that people can immediately pick up and then understand that they can achieve what's considered to be best practice in the operating environment in which they're in. So, and this piece of work's actually still ongoing. So there are webinars and podcasts and those guides and organizational case studies. And what we're now trying to do is move it into a national conversation, much like the previous example I mentioned in early childhood intervention. But what's missing, as you'll see, really, is that we don't really have that infrastructure in place to facilitate that conversation. So another example, I think a good one, where we've pulled together the best available evidence, but then within a kind of a model of change then about how you get that information out, we don't have those kind of features in the service system that, for example, exist in the US in terms of organizations like this KT Center. So let me just try and pull these examples together then, using a model of change. So just as a way of kind of making sense of these three examples and the extent to which they've worked or didn't work. And I sort of just proposed this model of change, which I've used before, which essentially sort of says, you know, when for successful change to happen, you need four key enablers. You need pressure for change, you need a clear shared vision, you need that capacity for change, and you need actionable first steps. And if one of those is missing, for example, if you have a clear shared vision and capacity for change and actionable first steps, but you don't have any pressure for change, then that effectively becomes a low priority. And in our case, I think in all three examples that I've described at the macro, meso, and micro level, we had fantastic pressure for change. You know, we had enormous pressure from using the voices of people with disability, families, and change. We've had extremely good bipartisan political leadership. We've had tremendous support from the sector or from the subsectors and from the practitioners in those sectors, and even more generally from the general public. There was a campaign for the NDIS, the Every Australian Counts campaign, and which is still ongoing. And politicians here describe it as the most effective public campaign that they've ever been on the receiving end of, which is why, you know, we sort of describe the NDIS as the biggest reform since Medicare. So they all had great pressure for change. I think they all had a clear shared vision, but really what we missed, I think, is the capacity for change and those actionable first steps. So I've talked about, you know, in terms of that pressure, that model for change, the peak on industry body being defunded, there was very, very poor market stewardship from the NDIA, and really a lack of clarity about roles and responsibilities. And so when I can sort of compare the Australian arrangements to the US arrangements, the thing that stands out for me in these three examples from Australia is really the importance of what I see in the US with the kind of knowledge translation architecture and infrastructure that is funded by organizations like NIDLA, like this knowledge translation centers, like having funding mechanisms that actually require that knowledge translation. When we directly compare Australia and the US, we look at the US with, you know, with envy, really, in terms of that best practice. So I'll start to wrap up. There are a range of resources, more information in the slide pack for those that are interested in more information on the NDIS or how it works. And for the two examples I've used, I've provided references to the resources and the other information that we've done. And there's also my contact details in that slide. But my main message really, just in wrapping up, was really don't take for granted what you've got in terms of the knowledge translation, the Centre for Knowledge Translation for Disability and Rehab Research, because when we look at that, it looks like the missing ingredient for us, which if we'd had, then the examples that I've given today would have been far more successful. It's not all bad news. I'll just end on the last point, really, is that the reason why I came over to the UK, the States, to do a Fulbright was to spend time with NIDLA and some of its grantees. And we are now in the process of setting up a National Disability Research Partnership, which will be a NIDLA-type entity, which will coordinate research, undertake knowledge mobilization, and capacity building activities. And that's being led by the Melbourne Disability Initiative. And there are my contact details if people would like to contact me about anything I've talked about today. Thanks very much.
Thank you, Gordon, for a fantastic presentation. So at this point, I would like to welcome Dr. Kathleen Mullen. Dr. Mullen, are you ready to begin?
Yes. Hi, everyone. My name is Kathleen Mullen. I'm a senior economist at RAND, as Donna mentioned. So I'm going to be talking, and I'm a policy researcher, so I'm going to be talking about disability policy research in the U.S. and trying to think about, building an evidence base that will help inform us about what are some potential reforms that we can do, when we're thinking about reforming the disability insurance system. All right. So I'm not sure how much people know about how Social Security disability insurance and actually old age and survivors insurance, the Social Security system is financed in the U.S., but in a nutshell, it's basically financed through a combination of sort of incoming payroll tax contributions and money from the trust fund. Or there's actually two trust funds. And according to the Social Security Board of Trustees in their most recent report, the combined assets of the old age and survivors insurance and disability insurance trust funds are actually projected to become depleted in 2035, which is about 16 years from now, with about 80% of benefits payable at that time. So we basically have about 16 years, give or take, to think about basically what are some ways that we can be reforming kind of the broader system. And we don't only have to be thinking about SSDI, we could be thinking about, interactions with other policies like the ADA, and I'll talk about that as well, and they all kind of feed together. So just a sample of kind of potential reforms that have been sort of proposed out there. We could introduce temporary disability benefits. Right now, our system is for permanent disabilities only, and you'll see, how that kind of comes in a little bit. We could think about mandating a private disability insurance, system, or experience rating employer contributions to try to incentivize employers to contribute or focus on their employees. We can think about changes in the disability insurance screening system, including potentially integrating it with vocational rehabilitation. And then finally, we can be thinking about, changes to just the way the system is set up right now, changes in the benefit structure, how much you get, changes in, potentially the 5-month waiting period for Social Security disability benefits or the 2-year waiting period for Medicare. So when you're thinking about the work, the research that I'm going to be talking about, I want you to kind of be thinking in the back of your head about how that research fits into, the evidence base that tells us how some reforms like this might affect, disability insurance rates or employment rates among people with disabilities. So, all right, how do we want to kind of think about this huge evidence base that we have on disability policy research, in the U.S.? And of course, this is not even thinking about, I'm not even going to be talking about evidence from other countries, although, that information is also particularly interesting, although it can potentially be difficult to think about how it might affect, things in the U.S. given just sort of different institutional features. Like an obvious example is the lack of universal health insurance in the U.S. And how that would obviously interact with people with disabilities who, obviously have health problems. So one organizing feature is to try to think about push factors and pull factors. So I'm, going to just kind of talk about 4 examples from each of these columns. Under push factors, just thinking about things that might push you out of work, right? Like lack of economic opportunities, lack of employer accommodation for, people's disabilities, discrimination that people might face in the labor market, and also interactions potentially with the application process itself. Just having to spend months and sometimes years waiting for a decision can lead people to have problems returning to the labor force in the event of an unsuccessful outcome, or even to try to reintegrate into the labor force if there is a successful outcome. And then on the flip side of that, pull factors are things like things that might pull you into disability insurance, right? So things like the benefit level or the replacement rate in terms of earnings, the availability of health insurance, the ease of the application process itself. The application process can present barriers in and of itself. And then just, social norms or networks. How do people find out about how to navigate the disability insurance process and whether or not it seems like it's something that, would be right for them? Oh, okay. So first I'm going to talk about push factors. All right, so real quick before I kind of dig into just, I'm going to skim over a lot of these because there's just a huge amount of literature on some of these topics. But the last 5 slides of the presentation give you all the references so that you can look all of these things up. So in thinking about lack of economic opportunities, the cyclical pattern in disability insurance claiming has long been recognized. So, I'm starting with studies going back to the 80s, and there's just this robust, level of research showing that that's still the case today. And then the next slide will show you just a sort of illustrative example of this. So here's a scatter plot of the SSDI application rate as it's the number of applications per 1,000 exposed, workers. So exposed here means that they're eligible for SSDI, but they haven't already claimed, so they're potentially able to be, into this pool. And then the x-axis shows the unemployment rate. And here I'm just showing you age-adjusted rates, so it's holding the age distribution constant for men, and we're looking between 1995 and 2018. So you can see that over this long period, when the unemployment rate goes up, disability insurance applications go up, and similarly, in more recent years, as the unemployment rate has gone down, applications have also gone down. And this is pretty much this nice kind of line that shows that relationship between applications and unemployment rate hasn't really changed very much over this time period. So the other thing to be thinking about in terms of economic opportunities here is just the fact that the disability insurance system in the U.S. is pretty much an absorbing state. So this is a little bit of an old reference. I couldn't find a more recent one, but less than 4% of disability insurance beneficiaries exit the program to return to work. So by far the most common ways of exiting the program are transitioning into old age, full retirement benefits, or retirement benefits when you reach the full retirement age, or death if it's before that age. And David Otter and Mark Duggan have this really nice 2003 paper in the Quarterly Journal of Econometrics that introduced this concept of the conditional applicant. So this is someone who's medically eligible for SSDI, but he or she works until they lose their job. And this actually feeds into some potential some other potential kind of push factors here. All right, so lack of employer accommodation. This can be a big part of this. So the Americans with Disability Act requires employers to provide reasonable accommodations, which could be any change or adjustment to a job, work environment, or the way things are usually done that would allow an individual with a disability to apply for a job, perform job functions, or enjoy equal access to benefits available to other employees. So there's sort of an empirical question out there if you're thinking about things that might affect employer accommodation is what is the unmet need for employer accommodation? So there have been a lot of previous studies that have looked at this issue, and they provide a really wide range of estimates. And a big part of this depends on how that at-risk population is defined. So here I'm just going to give an example of some recent work that I have done with some of my co-authors that finds that about 23% of working age adults could be considered accommodation sensitive in that they have a disability that could, if they were to receive some sort of accommodation at their workplace, would enable them to work longer or maintain their working hours. And then among these, about half, or maybe a little bit more than half, of these individuals lack an employer accommodation. So they could benefit from it, but they aren't receiving it. All right, so another side of this is thinking about employer discrimination. So the ADA also prohibits discrimination in the hiring of those with disabilities. If you think about the economic theory of this, the theoretical effects of legislation like this are actually ambiguous. And that is because employers could react by reducing hiring among those who are more likely to develop a disability, so they don't have to, potentially deal with those costs if somebody were to develop a disability later, and then they wouldn't be able to let them go. So the empirical findings of the effects of anti-disability or anti-discrimination legislation for people with disabilities are actually mixed, and again, sensitive to the definition of who has a disability. So here just are some examples of some literature looking at this from an empirical standpoint. And so I would say the jury is a little bit out on on whether or not the ADA has led to increased employment on net of people with disabilities. There's also just thinking about, so another way of kind of looking at this is to think about an audit study. So there was a recent audit study where the researchers basically prepared fictitious resumes and randomized, who had a disability or not, so they could hold everything else constant. And they did find that fictional applicants with disabilities received 26% fewer expressions of employer interest. And there were some mixed findings relating to the effects of the ADA thresholds on state laws. So this is an area of research where, or an area where I think more research could add a lot. All right, so finally, just thinking about the push factors here, there's also this interesting interaction in the US between human capital loss and the application process itself. And this really comes from the fact that applying for SSDI entails reducing one's earnings below the threshold for substantial gainful activity. So in 2019, the non-blind threshold for substantial gainful activity was $1,220 a month. So if you earned more than that, you're considered not disabled, right off the bat, and not eligible for SSDI benefits. So even though initial processing times for SSDI benefits are on the order of a few months, many applicants are initially denied and appeal their decision, and a lot of them get on through the appeals process at later stages. And in some of cases, they end up waiting as long as 2 years or more for a decision. And during that time, they're unable to work, or they're basically showing that they don't have a disability. So during this time, their human capital or their productivity could be depreciating, making it harder for rejected applicants to find jobs after the process is over. So I have some work with recent co-authors where we use random variation in examiner processing times for these applications to study, whether there's this scarring effect of application process itself. And we do find that that longer application processing times result in reductions in post-decision employment of SSDI applicants, both in the short run and the long run. So this is something that could be an area where changing the process itself could potentially benefit people. So a lot of that I just talked about is thinking about the labor market, right? So you're thinking about someone who has a choice between working or applying for SSDI. But there's also the flip side of things. What factors make DI an attractive alternative, something that would pull you into that system? All right, so one obvious thing here is the optimal level of, or the benefit level itself. So economic literature, the theoretical literature, shows that the optimal level of disability insurance benefits, or benefits in a social insurance system, generally, like unemployment insurance, balances the trade-off between insurance and incentives, or moral hazard in sort of economic, parlance. And basically what this means is that, on the one hand, people with disabilities that affect their earning power, they legitimately, are experiencing this bad shock, and you want to be able to insure them against this bad shock and provide them earnings replacement. But on the other hand, by providing this money to people, you're disincentivizing work, and you may be disincentivizing work among people who could work on the margins. So, the benefit level itself will kind of trade off these two things. So some recent work by Bruce Meyer, and I should know the first name of Mock, but I do not, applies this sort of classic social insurance model to the disability insurance framework. And they find that for a wide range of plausible parameterizations of their model, the current level of disability benefits is actually lower than would be optimal. So similarly, there's also recent work by Manasi Deshpande, Tal Gross, and Sue, who modified this model and try to incorporate consumption risk, bankruptcy, and then they want to consider the optimal timing of benefits. So they actually find that DI programs could avert more financial distress if benefits were awarded earlier. So this sort of body of research together suggests that maybe disability insurance benefits in the US are actually lower than might be optimal, and could be awarded sooner. So rethinking that waiting period could be something that policymakers could do. All right, health insurance. So health insurance is a little bit difficult in the US, and I already mentioned how when you think about incorporating findings from other countries, sometimes it can be difficult to think about how those, the effects of various policies in other countries, what that would mean for the U.S., because other countries tend to have universal health insurance, which the U.S. does not. So we do have the Affordable Care Act, which recently intended to reduce, well, actually did reduce the uninsurance rate from 20% in 2010 to 12% in 2018, although I think there's been maybe some recent evidence that shows that that's been kind of increasing again in the last year. So increased healthcare access actually should improve health, right? But often it doesn't. So there's research sort of outside of the disability insurance literature that shows that sometimes increasing health insurance or access to health insurance doesn't necessarily improve health, but it improves other factors like your sense of well-being, because you don't have to worry about losing all of your money because of a bad health event. But it's not just about health. So even with the ACA, the best way to get affordable health insurance in the U.S. is either through an employer or through Social Security disability insurance if you have a disability. So this just shows a little bit of a schematic that kind of illustrates how health insurance in the U.S. can be very complicated, especially for someone with a disability. So on the all the way to the left, we have somebody who's employed with employer-sponsored health insurance. So let's say this person experiences a disability that makes it difficult for them to work. They can either maintain their hours above the employer-sponsored health insurance eligibility threshold and keep their employer-sponsored health insurance, or if it's just sort of too painful for them, they could reduce their hours below the ESHI threshold, and if they apply for Social Security disability insurance or supplemental security income, they could receive Medicare or Medicaid through the program itself. And then there's all these other kind of options in the background too, like whether they receive their health insurance through their spouse, whether they can use COBRA to kind of maintain health insurance through that 2-year waiting period. And then, the private market is actually bolstered by the ACA. Potentially you could buy health insurance on the exchange. And then I guess actually I don't have Medicaid expansions that sort of happened as a result of the ACA as well in some states. So there's a lot going on here in thinking about how health insurance might interact with Social Security disability insurance. All right. So the theoretical effects of health insurance expansions are ambiguous, just because of this complexity. So on the one hand, if you are not eligible for supplemental security income and you have employer-sponsored health insurance, you may want to sort of stick it out with your current employer unless you can find some bridge health insurance through that gap. On the other hand, if you're unemployed or you don't have access to employer-sponsored health insurance, applying for disability insurance could be a way to get health insurance. So the theoretical effects of health insurance expansions, just generally not even thinking about the ACA, are actually ambiguous, and most studies find null or mixed effects, which is perhaps not that surprising. So I think the challenge in this literature is separating out, what are the theoretical effects of those channels? Are the people that we think who should be increasing their disability insurance claiming doing so, and the ones that we think should be decreasing, are they doing so? And that's something that's really hard to get at without a really strong research design and the right kind of data. And so I think there's potentially some areas there for work as well. In terms of the application process itself involves several costs. So mostly it's foregone time. The time it takes to potentially travel to a field office to get some help with your application or walk-in wait time. Once you're there, it may take a long time for somebody to get to you. If these costs deter applications from individuals with lower severity disabilities, then it could actually increase the targeting efficiency of the program, right? So that's the ability of the program to serve those most in need. So, on the one hand, higher application costs could really mean that the people who stick it out through the application process are the ones who are the most likely to benefit from the program. And then on the other hand, these are real costs that are incurred, by people, and so that's something you might want to minimize. So there's been some recent work by Manasi Deshpande and a co-author that found that actually recent field office closings led to large and persistent decreases in the number of disability recipients. And these tended to be concentrated among people with moderately severe conditions. So evidence points to the increased congestion at the neighboring field offices as the main channel. And what this means is basically that people who suddenly didn't have a nearby field office went to the next closest field office, and then you basically had a lot of people all going to the same field offices at once, and this increased the time that it took to get to a decision for these people. And then finally, there's some work by Andrew Foote, Michael Gross, and Stephanie Renan that shows that the switch to better access to high-speed internet post-2009, when SSDI applications became available online, increased more in counties with better internet access. So definitely there is some research showing that the sort of path that people need to take to get through the application process matters. All right, so finally, just the decision to apply for DI benefits may depend on social norms, what people, how people think about, receiving SSDI benefits versus potentially working. So this could take many forms. This could be, differences in values about how important it is to work. This could matter based on feelings about the government, and these could be amplified or kind of reduced based on one social network. So, and then in addition to that, social networks also make it easier for people to learn about the program and how to put together a successful application, get all of their medical files together so it doesn't take as long as it could, things like that. So Delia Furtado and Nicholas Theodoropoulos have a recent paper using immigrants as social networks, and they find that immigrants residing, amongst a large number of people in their same immigrant group are especially likely to receive disability payments if they're in an ethnic group that has higher DI take-up rates. They also find that immigrants from countries with stronger work norms are less sensitive to exposure to DI take-up within their communities. So this is evidence that how people around you react to disability insurance can make a big difference in terms of whether or not people apply or don't apply. Okay, so I started this off by basically saying here's a kind of list and some potential proposed reforms, and saying I'm going to try to walk you through some literature that speaks to the different channels that might be affected by these different reforms. So here I'm just kind of trying to walk you through how the different types of research in the different areas can speak to understanding how potential changes to the program might affect things. So if you're thinking about introducing temporary disability insurance benefits, understanding how economic opportunities affect long-run and short-run opportunities for people with disabilities, can be very important. If you're thinking about proposals that mandate private disability insurance or add experience rating to payroll tax contributions for employers, thinking about how much unmet need there is for employer accommodation and how effective employer accommodation is at increasing employment rates is important. Thinking about discrimination is also important, and how anti-discrimination laws could interact with these potential channels. If you're thinking about changes in disability insurance screening, you want to think about sort of how long that application process takes and whether the application process itself might deter applications and who it may deter applications from. And then, finally, if you're thinking about changes in just the way that the current benefits system is structured, you want to be thinking about how, recent research can inform, what that optimal benefit level should be and how the provision of health insurance affects people's decisions on the margin, and then potentially how people's social norms and networks could either amplify or kind of muffle out some of the effects of some of these, potential systems. So that's all from me, and I think this might have been a little bit like high level, so I apologize, for that, and maybe through some of the Q&A that might help. And as promised, there's 5 pages of references following this slide, so I think we'll stop now and say thank you.
Thank you very much, Dr. Mullen. That was very interesting. I know that we only have a few minutes left, but I do want to take some time for a few questions. So at this time, I'd like to invite Gordon, Kathleen, and our reactors to switch on their webcams, please. And so for our first question today, I'm actually going to direct it to Rosmeen. Rosemeen, excuse me, Gordon mentioned enabling features for change and barriers to implementation. Can you give us an example of barriers and facilitators to change that you've experienced in your field?
Yes, absolutely. So I work with my PhD work, I work in the area of health technology reassessment. And that's about not introducing new interventions, but reassessing interventions that we currently use in the system and how we can actually use them optimally. And that might involve actually decreasing their use, so removing them completely from the system. And some of the barriers obviously are where people don't want to let go of things when they're used to using them all the time. And so some of the barriers could be financial barriers. Some of the barriers, they also could be facilitators as well. Some of the barriers could be policy issues, as well as we could also have them as facilitators in terms of regulatory facilitators. So I think it's all about having that conversation and really understanding what the barriers and facilitators are. And in the previous presentation, I talked a little bit about the CFR and the theoretical domains framework as a mechanism to actually elucidate what those barriers and facilitators are. But I'd be interested in hearing from the panel on what you think about when we're trying to actually remove things from the system or decrease their use, what you think some of the barriers and facilitators are. Thank you.
Thanks. And so, I don't know, Mary or Meg, if you wanted to comment on that to respond to Rosemeen's question, or Gordon for that matter, or Kathleen.
Look, I think that's absolutely right. In the three examples I gave, the biggest impediment is always people's ownership of the current system. There's always kind of vested interests that don't want to change to new models of practice or better models of care and support. I think this issue about portability as well and context is so important. We undertook a massive exercise to basically look around the world and try and import different elements into a new system. So this idea that you can just sort of cherry pick from other places without considering the local context and local practitioners' weddedness, their existing organizational knowledge, their existing practitioner knowledge, that in our experience has always been the main impediment. So you've got to paint a picture of a different future. You've got to sort of reveal the gap, I guess, between their current practice and some better practice, and then how it will, influence better outcomes for the people that they're supporting, I think.
Definitely. And then, Meg, this question's for you. So Dr. Mullen talked quite a bit about disability insurance. And so the question is, from a rural perspective, being based in Montana, do any of the proposed reforms to disability insurance cited by Dr. Mullen seem more pressing than other?
Boy, I would say, the economic opportunities available in rural, if that's one of the reforms that she was underscoring, really, I think, resonate in rural America. And at the RTC Rural, we've had examples, successes of how to organize with rural communities to address economic opportunities in a way that realize opportunities for workers with disabilities, business owners with disabilities, and so on. I'm not sure I really understood some of the reforms that Kathleen was describing, so it's hard for me to respond directly there, but I can share that under the ACA, one of the products just that came out of the RTC rural with some of my colleagues was showing that access to health insurance through ACA, through Medicaid expansion, is being felt even more by rural residents. We're seeing in states where there was expansion more access to health insurance. So that's a report that just came out. But maybe Kathleen, you can underscore exactly what some of the reforms are that may be relevant to rural as well, from your perspective.
Yeah, I mean, I think it's a good question. So maybe the list of reforms was a little bit, I was trying to be really comprehensive about all the things you could do. And my area of expertise is Social Security disability insurance, you might have guessed. So a lot of it is thinking about how you might kind of tweak that program. But a lot of it is thinking about how it might interact with, different background kind of indicators. So, I think directly improving economic opportunities for people with disabilities is a hard, policy. It's probably something that's not going to come through a reform to the SSDI, system itself. Potentially you could think about, there have been proposals to think about integrating potential opportunities for vocational rehabilitation, but also you could think about job training opportunities that could be sort of integrated together into the application process. So, instead of going to a disability insurance, an SSA field office and essentially trying to prove, I can't do anything, and any sort of evidence otherwise is a ding against you. You could think about going to an office where somebody would say, let's kind of think through your case. What are your skills? What are your health problems? What are the opportunities in your area? And try to think about, almost like being a caseworker, right? And getting somebody, helping them try things out for a temporary period. And then if that's unsuccessful, or if it's obviously going to be unsuccessful, then going to the benefit period. I don't know if that helps or makes sense.
Well, thank you.
It does, and in a rural landscape, making sure that there's a variety of agencies and partners who can play that role, as you describe it, and just thinking about the individual's opportunity to access that opportunity to do that kind of employment support. So VR has so much reach in a rural area, and making sure that they are supported to develop those other partners to play a role with them in a coordinated way, so that rural residents with disabilities can have access to those supports as you describe them. I would also just say that, the importance of what you said about the field offices closing is really important to pay attention to on the rural landscape, and also just the quality of who's in those field offices, and just opportunities to access advocacy organizations like Centers for Independent Living when those field offices are closed, or there is somebody there who is not willing to work with an individual. All those things play out in really sensitive ways in our rural communities. And then for us, it's, just letting people know there are programs like Medicaid for workers, that there are bridges back to employment, and you can keep the health insurance that works for you, and how to put accommodations back together if you have lost your job and you do want to return to work. So just keying on some of what Dr. Duff said about case studies and how important they are. That's very true in rural America.